Thanks for cheering, Aldo. You're making me feel the love here. It's always good to be back in Canada. For those of you who don't know, I'll make sure I say about correctly because I was born here in this beautiful country, and I had the privilege of working here for many years in myeloma until I went to the dark side and crossed the border. Before I speak, it would be professionally embarrassing for me as a hematologist to have any of you develop what we call a DVT or a deep vein thrombosis. We're obviously running a little bit late. You've been sitting for 2 hours. Just take 30 seconds, stand up, stretch your legs, breathe, because we don't want anyone getting unwell as we go into this lecture. Sorry? If you want to, but we're going to take a break right after. So. Okay, so hopefully that'll just help keep you awake for the next. I was assigned 25 minutes. We'll try and shorten it up a little bit so that you can get a break in before the next onslaught of lectures. I was joking with Martine. I said, you know you're in BC when they schedule 15 minutes for newly diagnosed myeloma and 40 minutes for marijuana. Like, wow, you know, I'm like, I was anticipating handouts at the Vancouver airport yesterday. But anyway, so I have the daunting task to talk to you a little bit about relapsed multiple myeloma. Now, if you want to nap the whole weekend, right, the essential point here is that myeloma is clearly not the disease that it was when Aldo was diagnosed, as we heard earlier. We have made radical improvements in this disease. So I want to add to the enthusiasm of what we feel. The caveat always is there are beautiful and wonderful patients of mine who still die of this disease every week. And so although we've made a massive step forward, there are still aspects of this disease that are incredibly challenging. We've come to appreciate that really, as we heard this morning, in many respects it's called multiple myeloma appropriately, because even within myeloma, there's a very interesting publication just published last week looking at this notion that we probably actually have 6 different diseases embedded within myeloma. And we have some patients, and thankfully most of our patients now live more than 10 years, and I predict that we're going to see greater than 15 years on average before long. But there's still a subset of patients whose disease becomes very aggressive and succumb to their illness. A very dear patient of mine just passed away a few weeks ago, and his diagnosis was a year ago, and we gave everything possible to him, but he just had a bonfire that we couldn't put out. So it's sobering. So when each of these lectures, even when I come to talk about relapsed multiple myeloma, it's so different. We're not just trying to get brownie points with the patients when we say we want individualized care, we have to listen to the patient. It's absolutely true. There are no 2 myeloma patients that come to my clinic that are exactly the same. And I don't think of them as myeloma, the myeloma in room 4, right? It's very much an individualized disease. And the day is going to come, and I'm going to predict in the future, if I can be a prophet for a moment, in the way we look ahead to the future of myeloma, it's going to be very different than the way we do it now. Yes, we'll have a lot of these same drugs, but the influence of genetic testing, as we've heard, the day is going to come where you're never going to need a serum protein electrophoresis or a light chain test, because we'll do it all by mass spectroscopy. The day is going to come where you won't need a bone marrow, because we'll do it all on blood DNA. Now, there's a happy thought, right? I mean, oh, yes, please, stick a needle in my backside and make me feel good, right? So there are things that are going to change in the way we look at disease. So I show this slide, as I kind of mentioned to you, in both a happy and a sobering way. In a happy way, if you're not used to these curves, flat is good. This is sort of different than when you think of flatlining as not being good. Like, flat is good, right? Sadly, these curves, as people die, the curve starts to drop. So if I'd shown you survival curves in myeloma 20, 30, 40 years ago, they would have looked like Mount Everest, right? Sadly, people didn't live very long. So if you look at the bottom 3 curves, the bluish ones, we're seeing an improvement every few years in the average survival of myeloma patients. That's the happy part of the slide. The sobering part of the slide is that there's still a gap between that and the population of patients without myeloma. And so many of us in this room have dedicated a significant portion of our life to bridging that gap. And I have the privilege now in my role at the IMF of being around the world. In the last 3 weeks, I've been to Brazil, Australia, Austria, where we've seen huge variations in this curve. This is the American curve, essentially. But we see places, I'm in the favelas of Brazil, where these patients have access to literally nothing. If it weren't for some of the work that we're trying to do there, these people would have no hope with myeloma. So I'm partnering with you and Myeloma Canada and everyone in this room to work towards bridging that gap. So if I wanted to give you a sort of overview of where we are in myeloma as it applies primarily to relapse myeloma, and I'm not going to go through this in a lot of detail because obviously we don't have a lot of time, is that there are some major themes that are emerging in myeloma. We're treating people for longer periods of time. Not that it's completely a notion that every one of you will be on therapy for the rest of your life and you'll like it, right? That's not how we do it. But in general, we are treating people for longer. It's not quite like high blood pressure where we'd say, okay, let's treat you for 6 months and see, and then we'll stop your blood pressure pills. Of course not. You continue it, right? We haven't cured hypertension. We haven't cured diabetes. We just control it for the long term. So many parts of myeloma we treat for the long term. We are seeing the benefit of combination therapy, and I know this is sometimes sensitive in Canada because we can't always have access to them. In Australia, where I was last week, the government has never approved a combination therapy. They've never been able to put two novel agents together, and we're obviously advocating for that. So that sometimes it is better to have A plus B together than A then B, but that's not always the case. And then, of course, thankfully, we're working on side effect profiles and quality of life in a way that we never appreciated before. I mean, it used to all be quantity of life. Let's just keep someone alive. Now we actually can focus. We have better measures, and I'm delighted. I was teasing you about the marijuana bit, but I'm delighted that so much of the agenda here is dedicated to your own well-being. Because these are the kinds of things we never used to talk about in multiple myeloma. People's sleep hygiene and wellness and sleep hygiene. When I give someone high-dose dexamethasone, I mean, good luck. I mean, it's great to get your vacuuming done at 3 o'clock in the morning, but it was about all that was accomplished. So these kinds of things are so fundamental. And then, of course, there's the whole field of immunotherapy. And I'm not going to make you an immunologist overnight, and I know the slide looks scary, but let me share with you one aspect as a preview to what's to come tomorrow, and it's going to help us understand a few minutes that I'll spend on relapse therapy. I could argue that in many respects, this whole notion of immunotherapy that the whole world is going crazy over is more applicable to myeloma than any other cancer on the planet. Why is that? And I'm not here to creep you out, but myeloma in many respects is the most common cancer on the planet. Right? We're screening the whole country of Iceland, as some of you may know, in a research project at the IMF. So over 85,000 patients have already consented to have their blood tested. And we're discovering that MGUS, that precursor to myeloma, is a lot more common than we think. Again, whether you're here and you're a myeloma patient or a caregiver or working for Myeloma Canada, there are a lot of people in this room while I'm speaking to you that are trying to make an abnormal protein in their blood, right? Don't do it. Don't, right? Stop it. Don't do it, right? And so the immune system is the reason why we all don't get myeloma. Because of this first column, that's the 3 E's of immunotherapy. The first column is called elimination. Your immune system is trying to eliminate your tendency to become cancerous. It's like a really good teacher who sees Billy over here looking out the window when the lesson is being given and says, oh, Billy, listen, you need to listen to this. This is going to be on the final test. And it eliminates Billy's tendency to fail, because she brings the student back in. Your immune system is constantly, vigilantly doing that. And I have geek friends who spend their whole lives trying to figure out how that happens. There are labs all around the world trying to understand those mechanisms. It would be wonderful if we could leverage those mechanisms, bring more, if you will, good teachers into your immune system to eliminate your tendency. The challenge is it doesn't always work. So the second column kicks in, what's called equilibrium, which is to say there are times when you do make a little bit of cancer, but your body is able to keep it in check, right? If you've had MGUS, your doctor may have said to you, oh, it's kind of like a little bit of dust in the corner. It's there if you look for it, but it's actually not hurting you. It's such a small amount of disease that it's not hurting you. And this is why myeloma is so relevant to this, Because there are millions of people on the planet right now in equilibrium where there's a little bit of cancer in their system, a little bit of myeloma, but the body is able to keep it in check. Wouldn't it be great if we could understand that mechanism better and enhance that mechanism so that even if you do pass the elimination phase and you get to equilibrium, you don't actually develop true myeloma? I sometimes joke and say, a little naughty is good, right? I mean, we all need a little naughty in our life. If you don't have dessert every once in a while, there's something wrong with you, right? And I can prove this in the lab. I can put a small myeloma clone in a mouse next to a very aggressive myeloma clone, so two basically myelomas in the same mouse, and you're more like a mouse than you think. And I can show that if that little clone is there, it keeps the big one from growing. So the immune system has a mechanism of keeping the bad thing in check, right? If you never have a little naughty in your life, then you're more prone to go off the deep end and just eat 40 desserts a day, right? So that's the kind of thing that we're trying to understand the immune system. And the third column here is escape, where unfortunately the disease just escapes from the mechanisms that we try and hold it down. And sadly, cancer grows. So much of what we're doing in myeloma, and again, I'm not trying to steal thunder from the discussions tomorrow, but to give you a preview, an appetizer, as we treat this disease, is to understand that mechanism. My last basic science geeky slide is this one, to remind you, and I know this is like, there's no test, right? I promise you, right? The purple two cells are the myeloma cells. Everything else is the environment in which it lives. And myeloma, more than any other cancer, is less about the actual tumor, right? And more about its environment, right? So like I'm the Canadian pacifist, right? Just like you. But let me give you this military example. What if an enemy invaded the building across the street, right? How are we going to get rid of that enemy? So there are three ways potentially we could do that. Way number one is sort of the American model, right? We're going to find them, we're going to snuff them out, we're going to get them, right? So we blow up the whole building. Right? Relatively effective, but a lot of collateral damage, right? And I'm not trying to make light of killing. I'm just trying to give you a sense of it, right? And so that is kind of what we do, as we just heard, when we do stem cell transplant. I mean, bone marrow transplant is a big whopping dose of melphalan. It's like, right? We sort of launch a grenade into your bone marrow and wait for everything to clear and hope that the cells are going to grow back, right? And for some people it's effective and some people it's not. It's a very effective way of getting rid of the enemy, but there's a lot of collateral damage, as you know. So way number two is to say, okay, well, I know the enemy is on the 5th floor, so why don't I just target the 5th floor? Maybe I can just eliminate that 5th floor, just wipe it out, and that doesn't cause the damage. That's targeted therapy, and you're going to be hearing about drugs that are more specific, that target the myeloma and not the cells around it. That's very effective. So even in this slide, we have drugs that specifically target the myeloma cells and don't hurt the good cells around it. The third mechanism, I have 5 minutes left? I had 25 minutes, man. I'm like, okay, all right. So the third mechanism is to say, all right, I can't get into that building, but the danger of that enemy is that enemy has completely marshaled the resources of that building. It now occupies the power and the water and the Wi-Fi, right? If you want to make my two daughters completely ineffective, you just shut off the Wi-Fi. Like, they're done. Like, they can't do anything, right? So instead of touching the enemy, I can shut off the power to the building. I can turn off the Wi-Fi. I can play country music and irritate them to death. Well, whatever it is, and as I always say, I'm sorry if you love country music. There's therapy for that. So that's what we're doing in myeloma. And some of these drugs that I'm just going to give you a very simple highlight of, that's the kind of approach that we're taking. So instead of giving you drugs that just go and blow up all the cells, they're drugs that interfere with all of these networks that allow this cell to live. We cut off the communication to the cells, they say, or the Wi-Fi or the water or power, whatever it might be. That's how we're approaching myeloma. So when we treat relapse myeloma, we don't just say, this is what I give first line, this is what I give second line, this is what I give third line. You look at all the tools that we have, you look at the patient, and you look at the disease. Those three factors together, that little matrix of treatment-related factors, disease-related factors, and patient-related factors, and we say, what fits best? I suggest that 5 questions be asked by every oncologist or hematologist when they treat myeloma. Number 1, do I really need to treat the patient now? Just because you have that little regrowth of a schmutz of your protein, it doesn't necessarily mean that we have to get in there and get rid of it right away, and you'll like it, as we said, right? We're not going to necessarily, just because a little protein starts to reemerge. Now, I know it's incredibly stressful, and I'm glad there's a discussion around this tomorrow. The stress of relapse. It's very painful, isn't it? I mean, is this the appointment where my doctor's going to tell me that the disease has come back? I appreciate the magnitude of that. But we have to understand that the simple reemergence of a little bit of a protein doesn't necessarily mean that we need to treat. But as we well heard a few minutes ago, we also don't want to wait until it's destroying you to do something, right? The analogy is, and it's an awful analogy, but if I'm a runner, right? So if I see my friend running towards a cliff, do I have to wait until they're falling off the cliff to know they're in trouble? Of course not, right? In fact, myeloma used to be defined as falling off the cliff. Myeloma was defined by the so-called CRAB criteria that you heard about, the calcium elevation, renal or kidney damage, anemia or low hemoglobin, or B or bone disease, as we heard from Jens this morning. Well, now we call it slim CRAB, right? So this is my whole contribution to the myeloma community. I came up with this, and that's it. Now I can die, right? I've done it all. But because what we've done is we've come to appreciate that it's not necessarily falling down the cliff. What matters is how far away is the cliff and how fast am I running. So just because someone's gone for a run, if the cliff is 10 kilometers away, and no one, and it's not going to be there anytime soon, we can wait and watch. So we have systems to decide when do we need to treat patients. If someone just has a change in their blood, we might watch them a bit more closely. If that thing starts to accelerate, then we'll intervene with treatment. Question number 2, should I retreat? This is the hardest thing to convince an American hematologist. Because Americans are like, oh, new shiny drug, right? And they go to it and they don't look back. But if something has worked for you before, right? I've had many patients who got Cybor D in a transplant, relapsed years later, let's do it again. Let's do Cybor D in a second transplant. Now, sometimes some of you might say, don't do it, right? Don't come near me with another transplant, you evil man. But, it depends on the patient, the situation. We may be able to use what's been used before. And again, this is recorded, and my slides are always available. I'm not going to go through them because I'm going to get the cane here in a minute. Maybe the most important question is, have I employed the big 8? And there's no way I'm going to go through all these drugs with you. And I know some of them are not yet available or may not be available ultimately in Canada. But this talk used to say, have I employed the big 3, and then the big 5, and then the big 7, and the big 8, and soon it's going to be the big 10. We want choices, right? This is not a game. But I tell patients, I want as many cards as possible to play for you. And I want to play the best card for you, but I also want to play the card that lets me play other ones later, right? You know it's that when you play Uno or something, like there's a way to, that's that multicolor card. I want to save it for later. But we also don't want to save it for too long, because then you end up losing the game and you have all these great cards and but I could have. Too late. That's an important analogy, because we don't want to be shortchanged. And sometimes, historically, myeloma doctors have said, let's save the best for last for you. And sadly, we've shown that if you do that, patients won't get to that last treatment, because sadly they would have succumbed to their disease earlier. So we are playing, if you will, the better cards earlier on. Number 4, have I used the add-on agents? This is where the Canadians shine, not because some of these drugs may not be available, like panobinostat, doxorubicin, as we've heard, but being able to use Dex correctly, being able to use cyclophosphamide. I know Dex, we love and hate it, but I can tell you my experience at Mayo Clinic for the last 10 years, somewhere around a third of patients benefit from taking dexamethasone at night instead of the morning. Your doctor should be asking you that. Are you the kind of patient who you take the Dex and you don't feel anything for 5, 6, 7, 8 hours, and then you start feeling jittery and your spouse wants you to throw you out of the house, right? When does that, I ask patients, when does that happen? Does it happen right away or hours later? If it's hours later, maybe do a trial for the month of taking the Dex in the evening instead of the morning. It might let you sleep better that first night. And then lastly, and this is my last of the 5 questions, have I considered an individualized risk-stratified approach? And this is perhaps the most important question. Deciding on all those drugs isn't so simple as a cookbook, thou shalt use drug 1 and then 2 and then 3. It really is, what is going on with the patient, what's going on with the disease, and what's going on with the treatment. And is this a patient that has kidney damage and I want to be careful with the dosing of this drug? This is a patient who lives 3 hours away from the clinic and they can't come in twice a week for an IV drug, and I'd prefer to go with an oral drug. This person has a really high-risk, rapidly growing disease, so I better use multiple drugs together. That's the kind of approach that we take. And so we have lots of options, and you'll be hearing about all these different combinations. It's like a alphabet soup. It's impossible to keep track of it all, but that's why we don't just choose one, we choose approach. So in a simplified way, we tend to think of what we call early relapse, when someone has had 1 to 3 prior lines, later relapse, and then very late relapse, when someone has really been so-called refractory to, or their disease has broken through all the different treatment strategies. And we've come to learn that the depth of response is important, and we want to treat people differently if they have high risk versus standard risk disease. So I'll just show you from a sort of a mnemonic picture. Like here we've got someone usually gets bortezomib up front, and maybe a transplant if they're eligible. But now we have all of these options. I'm not going through them. I'm just trying to give you a flavor. We have all these options that we never had before for early relapse, and indeed for later relapse, we have lots and lots of options. And there's no point, becoming Charlie Brown's teacher today, wah, 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 and the following study demonstrated, I'm not going to do that for you. I just want you to understand that you have lots of options, and many of them are powered, as we've just heard, by these so-called phase 3 trials, where we've done really big studies to show that certain strategies are better than others. I'm going to close by talking about this because I think this is absolutely fundamental. If you forget everything else I say, I want you to remember this. The power of communication with your healthcare team is unbelievably important. The plenary abstract presented at our American Society of Clinical Oncology, the biggest cancer meeting in the world last year, they choose 4 top abstracts. They chose one abstract that I think may well have a prolific impact on the cancer community. What they did was, they had patients, it wasn't with myeloma actually, it was with different solid tumors. They took patients and they so-called randomized them, so they separated them into 2 groups. Half of the patients, they gave them an iPad, and they had a special communication system set up between them and the nurse and the physician taking care of them to immediately communicate their symptoms, their questions. And then the other half were just sort of the usual, right? Call, leave a message, get a message back, play phone tag back and forth, eventually. And I'm not saying that's a bad system that we have now, but they were trying to prove that with enhanced communication and open communication with our healthcare team, those patients could have an improved quality of life. And sure enough, they proved it. But what they proved more that they hadn't anticipated is that that group of patients didn't only have a better quality of life, they had a longer survival. So to reiterate to both the treating team, it's important to listen. You had 2 ears and 1 mouth for a reason to your patient and communicate well with them. And also for you as patients here today and caregivers, to ensure that you try now. You don't want to be the person that leaves 48 messages for the myeloma clinic, right? Because that could be very bad, right? That can be a bit irritating after a while. But you want to ensure that a system is set up so that you can have that ongoing communication. So to close, we have 4 big classes of drugs now in myeloma. What are called proteasome inhibitors there in orange. In blue, the immunomodulatory drugs. So proteasome inhibitors end in MAB. Immunomodulatory drugs end in MIDE. And then monoclonal antibodies in green end oh, that was bad. Let me start again. The orange proteasome inhibitors end in MIB, so bortezomib, carfilzomib, ixazomib. The immunomodulatory drugs end in MIDE, thalidomide, lenalidomide, pomalidomide, and the monoclonal antibodies end in MAB, daratumumab, elotuzumab, cetuximab. So you've got the MIBs, the MIDEs, and the MABs. And then you have old school chemo, the alkylators, the drugs that we use, as we've mentioned, for transplant and others. The day is going to come where we're going to see new drugs this weekend like selinexor and venetoclax and CAR T-cell therapy that are going to be other pillars that we're going to use to try and take down this disease. Thank you for your time.